joining the National Headache Foundation's chat on post-concussion headache. Today we have with us Dr. Roger Cady, and he will do a brief overview of post-traumatic headache, and then we will start taking questions.
Well, I want to wish everyone good evening. I think tonight we have a very interesting and exciting topic to discuss, which is, of course, post-concussive headache. I would suggest to you that it's probably one of the most highly publicized headache disorders, at least in recent years, yet perhaps one of the most misunderstood headache disorders, and truthfully one that is lacking a lot of good scientific study. You know, I think most of us, when we think about post-traumatic headaches, think back to days of our childhood when we watched cartoons and we watched anvils fall on the head of our favorite cartoon characters, or we watched the Roadrunner get blown up with a box of TNT, and we thought about trauma, particularly to the head, as sort of humorous. Unfortunately, for millions of Americans, it is anything but humorous, and it can be a very chronic and disabling disease. I think the other thing that's happened, over time is that very often people with post-traumatic headache have been discredited, often because there may be lawyers involved in their care. But I think that is changing, and I think it's changing largely because of all of the publicity on sports injury and the changes that occur with repeated trauma and repeated concussions, not only headache, which is the most common symptom, but also many other types of symptoms that can occur. And of course, in our military theaters of action, the idea of blast injury. And I think these have gone a long ways to begin to finally legitimize the post-concussive headache. If you think about it, there's many, many ways that people can end up with a post-concussion or post-traumatic headache. It includes like sports injuries, blast injuries, motor vehicle accidents, recreational injuries. And ironically, I think we have to try to express and explain a little bit about how often the less trauma that occurs, at least in terms of fractures and other things, often translates, the less trauma translates into a worsening or the most serious, if you will, post-traumatic headaches. So there's this curious paradox that we might have. Well, I'm sure there's many, many people out there with questions, so I'm just going to turn it over and let's answer questions. Thank you.
Our first question, Dr. Cady, comes from Cady. Are chronic migraine sufferers more prone to post-concussion syndrome?
You know, Cady, that's an excellent question, and the simple answer is yes, but probably the more perplexing answer is why. You know, if you think about all human beings are probably born with a threshold at which the brain, the nervous system can express headache. If you look at infectious diseases, you look at traumatic diseases, you look at things such as migraine, tension headache. Headache itself is almost a universal experience. The issue is, though, what is the threshold? And that varies greatly from one individual to another. And if you think about the disease of migraine, we're often talking about minor perturbations in a person's environment, say a change in the weather, a change in their hormone status, change in diet or sleep, and that can provoke this serious neurobiologic disruption that we interpret as migraine. Obviously, many people undergoing that same sort of change in their environment get no headache whatsoever, or their physiology seems not to even be aware of it. So I think the way to think about this is that if you have migraine, you are already several rungs up the headache ladder, if you will, or up the threshold to headache from people who rarely or never get headaches. And so if you experience trauma or some assault, you're going to be much more likely to express headache than a person that's never had migraine or is very lacks any proneness to a headache disorder. That's a very good question. Thank you.
Our next question comes from Virginia. Does taking any medications actually slow down healing?
There's a couple things about medication. And this really comes in light, for example, when people are elite athletes, for example. And we can put them on medicines that may disguise or blunt or hide the symptoms that their nervous system is expressing, and in doing so, we can misinterpret the damage that's occurred in the nervous system itself. So I think one thing that your question may be alluding to is that, before people are cleared to return to normal activities, it's very important that we evaluate them after the medications we use to assist them, are all cleared from their system. So we really can make sure that the symptoms that reflect underlying damage or problems in the nervous system have really subsided, and they're not just being masked by our medications. I think the other thing about medications, there's sort of two ways we organize our thinking around medication for any headache, including post-concussive or post-traumatic headache. One is to try to make the nervous system more resistant to headache. Many other drugs that are commonly used to treat primary headache disorders can be used. And the goal here is to actually elevate or increase the threshold at which the nervous system is activated to generate headache. And then, of course, the other large group are medications used to treat headache once it's happened. Ideally, those medicines turn off the physiology that's generating headaches, but many times we're really left with just trying to suppress symptoms and improve people's function with headache. One of the ways we kind of organize our evaluation of somebody with a post-traumatic headache is to look at the phenotype or the type of symptoms that are being expressed by the nervous system. So in that evaluation, you may look for symptoms that reflect more of the pathophysiology or the mechanisms that we think of with migraine. We may look at symptoms that reflect more of the mechanisms for tension-type headache or even cluster headache. And then it's based on that type of phenotype or that type of symptom expression that we often choose medication. So if that looks like migraine, we probably would treat with many of the medications that are used to treat migraine. Tension headache or cluster would obviously have their own set of medications as well. I can tell you that the most commonly expressed symptom complex in post-concussive headache actually looks more like migraine than anything else. And so people often end up with migraine medications, particularly on the preventive as well as the acute treatment end of their attack.
Dr. Cady, the next question will come from Nancy. Can you explain a bit about the treadmill test athletes use to determine if they are ready to return to play and why that isn't used on non-athletes after a concussion?
Nancy, the second half of your question is really very critical, and I don't have a good explanation for that. But I think I tried to allude to that in the previous question, that part of the protective physiology, if you will, part of the reason you have headache and dizziness and perhaps cognitive impairment, or you're not sleeping, or these symptoms that persist, part of the reason that that's occurring is because there's been injury to the brain. And so, we can use medications, of course, to sort of bury those symptoms. The most obvious example of that would be to give somebody an opioid analgesic. We're not correcting anything with that medication, but the person who takes it may not any longer recognize or have the symptoms that the medicine may take away, such as their headache. And so things like treadmill tests and other types of physiologic testing, it's done way beyond that, is to really try to simulate real-life situations that this brain is going to go through after we've cleared somebody to return to their normal activity, or in many cases to sports activity. So, that's why it's being done. What you really want to do is make sure that when people are sent back, particularly to competitive environments or to the military environment, that their brain is functioning normal. Now, in terms of the second part, why isn't this done for more people? As I said, I really don't have a good answer for that. I think very often we probably should be doing more of that type of testing. We should kind of, see how people are going to respond to the normal environment. I think very often what happens is people just get told to go out and go back to work or go back and do whatever they've been doing and then see if they can or can't do it. It's not a very legitimate way to evaluate it, but I think unfortunately that's often what happens. And I would concur with the intent of your question and suggest that more physiologic testing is probably worthwhile for many people that have a post-concussive headache. Thank you for a very good question.
Our next question comes from Gina. Can viral infection exacerbate post-concussive symptoms?
Well, again, I will go back to this idea of there being a threshold and suggest that probably all nervous systems, all brains, have a physiologic potential to express headache. But there is a wide variation in where that threshold lies. If you're born with the genetics of migraine, as we talked about earlier, that's going to mean you're closer to that threshold to generate headaches. If you've had an injury and it produced headaches, even if the headaches resolve, repeated injury or other assaults on the nervous system probably do make it more likely for you to, again, express symptoms of headache, other symptoms that associate with headaches, such as light, sound sensitivity, nausea, dizziness, cognitive change, muscle tension, pain, etc. So I think your question is very insightful. If somebody's had injury and now they get a viral infection, they're much more likely to, in sort of an additive way, if you will, start having symptoms again. And again, I'd say the same thing for somebody who is inherently a migraineur. They came with the genetics susceptibility to that, and if they get a viral infection, they are probably much more likely than a person that does not have that genetic predisposition to have a headache. And when they do, the headaches are often more severe, intense, and if they have migraine, more like migraine. Now, the use of antivirals, that's a very interesting question as well. I have done this in some people. There's, like in most of the treatment of headache, there's no strong evidence base for doing any of these. But the idea of using these are that if there are in fact reactivation of viruses or somebody has an active virus, we may be able to use some of these antiviral agents to help attenuate and assist in relieving a person's headache. But I have to say that there really is no scientific study or evidence base to support this. There is a certain sense of logic, and I think this is what many physicians follow in trying a trial of something, one of the antiviral agents. Thank you for your question.
Our next question comes from Lisa. Can you comment on the use of increasing exercise as a treatment for long-term chronic post-concussion symptoms, including chronic post-traumatic headache greater than 1 year?
Well, actually, I think one of the things we're learning, and again, I've got to stress the fact that we don't have a lot of scientific study when we talk specifically about post-concussive headache. There's probably been more scientific study in the last 5 years than in the previous 50. But if we look at other headache disorders such as chronic migraine, it's becoming very clear that regular, sustained and enduring exercise is a very positive thing and assists people in controlling their headache symptoms. So, I think for a lot of reasons. It may be because of endorphins. It may be because we start to normalize and kind of aren't in kind of that sick role, if you will, of not being able to do anything. We see maybe a light at the end of the tunnel. There may be lots of reasons that exercise helps. And I strongly encourage my own patients to begin this process. And again, because exercise done too vigorously or too early can actually aggravate headache, as you suggested, Lisa, the way to do this is in a slowly progressive prescribed exercise program. And again, I certainly recommend this for my own patients. And I'm delighted you asked that question. So thank you.
Our next question from Thomas. What do you think of Butterbur?
Well, Butterbur has studies for headache, migraine specifically. And, you know, I'm unaware of any studies that have been done in post-traumatic headache. But again, going back to what I was alluding to a little bit earlier, the way we really define treatment for an individual with post-concussive headache is to look at the types of symptoms they're having and then align them with some of the primary headache disorders that we understand. So for example, if a person's headache is throbbing, made worse with activity, moderate to severe, capable of producing disability in terms of preventing them from normal activities, they get light and sound sensitivity, nausea, etc., that would fit into a phenotype or a presentation that if there was no history of trauma, we would say that's migraine. And hence, we would look at all of the preventative medications and acute treatment medications that we might use for migraine in an effort to control that type of headache. And in that context, Butterbur can certainly be a tool or a treatment option. This can be used alone. It can be used in combination with other preventative medications. And, you know, I think at the end of the day, what we're often doing is trying to put the best tools we possibly can and give people access to that and understanding of how to use it effectively, you know, and able to control their headache pattern and to resume a more normal and functional lifestyle. So again, Thomas, there's no studies I'm aware of that specifically look at post-concussive headaches, but Butterbur is by and large well tolerated, and like I said, particularly if people have sort of that migraine picture to their post-concussive headaches, I think it could be a viable treatment option.
Are there imaging techniques other than CAT scans or MRIs for detecting abnormality?
That's another fascinating question, and the answer simply is yes. The problem is they're not tests that are readily available, but more in the research arena, at least as they're understood in post-traumatic headache. And the two tests that really come to mind are functional MRIs and PET scanning. And basically what this looks at, instead of just physical structure in the brain, like the blood vessels and various lobes and the nuclei or pieces of the brain, it looks at their function. So you can see areas that activate or don't activate appropriately based on various stimuli or metabolic challenge, etc. And they create a very different picture than the more structurally based studies such as the MRI and the CAT scan. So these do show types of injury. They show a lot of micro damage, if you will. They show changes in the way metabolism occurs in the brain itself. And like I said, these are used in research a lot. They're a lot less available in standard medical care. But they're very important to our understanding of mechanisms and what we think is going on and occurs, or defining injury in some cases that occurs secondary to trauma.
All right, it looks like Cady has a follow-up question of why are antidepressants so frequently used in treatment of post-concussion headaches?
Well, actually antidepressants do have a place mechanistically in understanding headache. Most antidepressants work by blocking the metabolic breakdown of important brain chemicals such as serotonin or norepinephrine. Others work on a neurotransmitter called dopamine, but the idea is to actually be able to increase the amount of these chemicals in the brain, and in doing so allow a more normal transmission or communication to occur in the brain. Now, the only thing that sometimes has to be brought to bear here is some of the antidepressants actually change a threshold of seizure, and sometimes if people have had trauma, that can be something that needs to be considered. On the other side of this, not only do antidepressants help restore a more normal brain chemistry. They also can help with sleep, and I would argue that sleep is kind of nature's cure or nature's method of treating almost any headache disorder. So kind of restoring people's sleep. They have an analgesic or pain-relieving benefit in and of themselves. And then finally, very often when people have prolonged headache disorders, there are psychological responses. And I would argue that there are physical responses as well, that when you get hit on the head, it may change your motivation, it may disturb your sleep, it can change your mood, your enjoyment of life. And when these things are prolonged, it actually can lead to things like depression. Certainly it can lead to anxiety or that state of heightened awareness. And so these drugs can be utilized to assist in the management of post-concussive headaches, as they can be used in the management of things like migraine headache or tension headache. The important thing to recognize, Cady, is that this is not saying that the headache is caused by psychological issues, and that's very important to understand. If you look at any transmission in the brain, there are kind of two areas of brain that function in interpreting a pain experience. One of them we call the somatosensory, and that's the part of your brain that tells you where you've been hurt, what's hurt, what it feels like. It localizes exactly where the pain is, and it's all about protecting that area from further injury. The other part of pain that is initiated at the very same time through a different set of nerves ends up in what's called the limbic system. And that part of pain looks kind of through our catalog of life and says, okay, have I been here before? What's happened to me? And ultimately, in some way, is trying to interpret a sense of safety in the world around us. And to resolve pain of any sort, we need both the somatosensory or tissue healing, and we need to come back to a perspective or an understanding physiologically and probably psychologically that we're once again safe in our world. Otherwise, we tend to stay in a state of hypervigilance, in a very watchful state for fear that something bad's going to happen to us again. So I know I've said that in probably an oversimplistic way, but I really want to make the point that there is no distinction between what normally we think of as physical and psychological. These are responses in the nervous system that are absolutely intertwined, and because a doctor or a healthcare professional prescribes an antidepressant, this in no way should suggest to you that the symptom is psychological rather than physical.
In your practice, have you seen full recovery from post-concussive head pain in patients suffering for more than 1 year? Is there a correlation with age, i.e., the younger the patient, the better the chance for full recovery?
Very interesting questions. First of all, realize that most post-concussive headaches actually resolve spontaneously on their own and typically within weeks. So if you looked at 100 people who had trauma to their head, the vast majority, probably 80% or so, are going to have resolution of that. The other, and as headache gets out, we change it from an acute post-traumatic headache to a chronic, and that is when people have persistent headache and other associated symptoms that go along with the concussion. And specific to your question, I have certainly seen people who've had these types of headaches for greater than a year respond to therapy. Part of this is understanding that there are lots and lots of structures that can be injured with a head trauma and produce pain. And that can, start with the skin, it can go to the muscle layers, it can go to the covering of the bone or the periosteum, it can be damage to bone, it can damage or injury to the linings around the brain, and it can be to the brain itself. And so sometimes you can have things like nerve entrapment, you can have secondary types of consequences such as prolonged muscle spasm, which may or may not, again, cause nerve entrapment. You can have injury to soft tissue structures. And also, contrary to what a lot of people believe, the brain has the ability to heal as well. It tends to be a slower process, but with the right types of stimulation, treatment, and diligent work, it does have the ability to respond. To the other part of your question, I think it's probably fair to say that, age, as in most injury, young people tend to respond better than more mature people, but I wouldn't use that as an absolute value. I think there's just a certain physiologic resilience that we have when we're younger, and as we get older, the depth of that resilience is perhaps a little less. But again, I wouldn't give up just simply because I've reached a point like 1 year or 2 years. You get into more of a rehabilitation model of care rather than a magic bullet. And by that I mean it may take kind of an interdisciplinary approach where you work with a physical therapist, you work with a medical provider, you may work with a psychologist, you may work with an occupational therapist to learn different ways to do certain activities, etc. Whereas early in an injury, it's probably pretty much the standard medical model of taking medicine and giving nature time to heal.
Can you give some ideas about what type of treatments you use with your patients if they have migraine-type symptoms following a concussion?
Yeah, sure. Again, that's actually the most common presentation. And so I think if I'm understanding things correctly, you're asking me, most commonly somebody has migraine. They may be very infrequent. They may be very treatable. Then they have an injury to the head, and suddenly they're developing headaches that look like migraine or may even be, exactly or very close to the kinds of headaches they had prior, except now they may be more severe, they may be more disabling, they may be far more frequent. So, the first thing to look at in evaluating this is the pattern of headache, which is largely around, how commonly headaches are occurring. And if you think about this, when we have migraine early in life, typically you have a headache that comes, it goes, there's a period of time before the next migraine. And during that time between headaches, people generally return to normal, and the nervous system has an opportunity to basically, restore itself and resolve the headache before the next headache occurs. When you have a traumatic event, what often happens is headaches are being generated so frequently that restorative time period is lost. So the nervous system never comes back to feeling normal or fully recovering from migraine, and people end up, with a low-grade headache between attacks, or at the very least, they feel like they're on the edge of their next headache. So the first thing is to look at pattern, and when you see very frequent headaches, we use many of the same preventative medications that we use in treating migraine. So we can use things like tricyclic antidepressants. Those are things like amitriptyline, nortriptyline, those types of drugs. You can use SNRIs, and these relate to norepinephrine. These are things like Cymbalta, Effexor. Those have some benefit in this arena. You can look at beta blockers. You can look at a host of medicines that have indication as a migraine preventive, such as topiramate or Topamax or Depakote, divalproate of sodium. There are many others that don't have an FDA approval that are commonly used that, again, fall into the group of drugs that we call anti-epileptic drugs. And the goal of all of those medicines is to protect the threshold to your next headache. So it makes the nervous system less likely to generate its very next headache. From an acute treatment perspective, ideally we'd like to use symptomatic medicines that stop migraine and stop it long enough that the nervous system can begin to recover between episodes of migraine. So if you take one of the triptan medications, that would be sumatriptan, zolmitriptan, rizatriptan, there's 7 different triptan medicines. The ideal response would be to stop the headache and stop it long enough that the nervous system can approach a more normal level of function and time to begin recovering. We also use non-steroidals. They can be used as an adjunct. That's the things like naproxen, diclofenac. There's a whole host of those medicines that can be very effective. When those don't work, we end up going to a lot of things that have less and less evidence for them. Sometimes we'll use more pain-type medicines such as gabapentin. Other times we can use other of the anti-epileptic or anti-seizure type of drugs that, again, don't necessarily have approval but may be of benefit, even out to the point if migraines are chronic enough to considering the use of onabotulinum or Botox if people are having more days of migraine-like headache in a month than not. So there's a whole host of medicines, and then I would suggest there's a lot of things that can and should be added as adjunct, including education so people can feel more involved and more connected to their treatment, have a better understanding of it. You may want to use things like physical therapy. Often there are injuries to this soft tissue and muscle fibers. As I mentioned, the use of psychology, learning things like biofeedback, developing a cognitive approach to how you're going to look and understand the headache itself, occupational therapy, which may look at ways in which you can perform certain functions more effectively and more easily than you might be doing right now. So, you know, that's kind of a very broad overview, and I hope that's helpful for you. Thank you.
Our next question comes from Anne. My 20-year-old son had his first concussion about 2 months ago. He gets occasional migraines. He's a college football player and has not been cleared to return to play yet. His biggest concern is about the lingering effect from the concussion. He currently gets very lightheaded, including when he's moving out of his dorm. Will this go away? And also, he's lost memory of the first 2 days around the concussion. Will that memory come back?
Well, that retrograde amnesia, or that loss of memory around the traumatic event, is not an uncommon symptom at all. And he may regain some of that, but if this has been out for a while, you know, the longer he doesn't have it, the less likely that is to return. I think your question is really an important one, and there's several levels that I'd like to address. And we've talked about clearing people to return to function. And when you talk about athletes, that takes on special meaning. Because very often, if, for example, we were to do reaction time testing on somebody with a head injury, you will see that the reaction time is slowed significantly. Now, I know when I played sports way back in the Stone Age, the idea was your coach went out and said how many fingers, and if you could say 3 and you were close, you got to go back in the game. And what's been observed is just this incredible risk of re-injury because the brain's not functioning. Your protective mechanisms that allow you to play sports in the first place just aren't in place. And so the second injury and the third injury. And what we're really learning is concussions are accumulate in terms of their negative effects on the nervous system. And I'm sure most of you are well aware of very high-profile lawsuits, National Football League, etc., where these world-class athletes who had multiple concussions are having a plethora of different problems, many of them related to their nervous system and early deterioration of the nervous system. So I applaud the physician who is helping your son manage this, and I'm sure he's disappointed, but if he's still having lingering symptoms, it's really important that these be monitored out to resolution. And I would suggest, again, it's resolution without medication. Again, I guess everybody wants to be next Pro Bowler for the NFL, but I think so often in high school and even college sports, we need to think about the larger picture of our life and be certain that we're protecting that and not the immediate gratification of getting back out there and then risking re-injuries. So I don't know how long your son's out from his injury, but I would definitely support the idea that if he's still having symptoms and the dizziness and lightheadedness that he's experiencing, that needs to be resolved, and again, without medication before I would support putting him back into a competitive environment. I would also point out that, you know, athletes today, and especially at a college level, are so physically developed. And if you don't have all these protective mechanisms, you know, available to you, the risk of re-injury goes up significantly. So it may not be what you wanted to hear, but I feel quite passionately about the need to really protect the nervous system and think about the long-term consequences in somebody's had a concussion and preventing that from occurring again.
Our next question comes from Thomas. Do you think I would benefit from vision therapy if I received vision convergence issues and brain pain from a hit to the head 2 years ago?
You know, Thomas, the honest answer I can give you is I don't know. You know, again, one of the problems in dealing with post-concussive headaches is really a lack of scientific evidence to support our treatment. As I said at the beginning, probably more science has been generated in the last 5 years than in the previous 50, but understanding and treating post-concussive headache is in its infancy. So the way that I look at something like that is to ask, first of all, is it safe? You know, in medicine we have a saying, to do no harm. And, you know, that vision therapy certainly is going to do no harm. So starting with that premise, I would not have any qualms in suggesting that somebody do that. What I do in my own patients when we kind of go down these pathways is try to set up an objective measure by which we're going to define success. And I try to do that personally through improved function. Am I able to do things, enjoy things, have more fun with my life? And obviously you want to reduce pain and stuff, but I really try to look at the functional aspects of recovery. And if we can define that and see that it's improving, you know, I'd go for it. Again, I think the primary question here is to, you know, do no harm. And again, I think the therapies you're asking about are very safe.
Our next question from Jason is it possible to get chronic daily headaches that begin years after a concussion or years after a bout with bacterial meningitis?
Well, again, I think what we're learning is that previous assaults to the brain do set people up. You know, if they have a second assault to the brain, they're more likely to have more chronic symptoms. You know, the question itself is without good answer. But for example, if somebody's had one concussion and gets another concussion, or you know, they've had a migraine in the past and then they get a concussion, or they've had an infection and get a concussion, or they have migraine and then get an infection, all those second assaults tend to alter and change the threshold to develop your next headache. So you asked me about the development of chronic daily headache. You know, there's so many factors that can come into play, including medication use and misuse or overuse. It can be alterations in sleep that can be a major factor, major life stressors that can occur. The way that I try to get my patients to look at this is like we're putting together pieces of a puzzle. And when the puzzle's together, we see success. And there's no one piece that allows us to understand that whole picture. So when you've been years out in a disease, the odds of finding a magic pill or a magic bullet is pretty darn remote. But by the same token, you don't have to have every piece of a puzzle to know what the picture is. So you start breaking the problem down into smaller pieces that do have a logical and reasonable approach to helping resolve it. And as you put more and more of those pieces into play, the odds of success and improvement go up significantly and dramatically. So I know I'm not giving you a real direct answer, and the truth is I don't have a direct answer, but those are kind of the ways that I would approach someone who has a problem with chronic daily headache. following injury or infection.
How do we figure out the damaged part from our concussion, muscle spasms or nerve entrapment?
Well, unfortunately, the best way we have today, and it's a pretty blunt instrument, is symptoms. And that's very important to sort of get at the root of that. And sometimes that sounds simple, but it's not always. You know, take, for example, an athlete. They know if they discuss their symptoms, or a soldier wanting to get back to his unit in the theater of combat. They can often sort of disguise symptoms. Very often when I've brought spouses or close friends of somebody with a post-traumatic headache and they're telling me how good they are, you ask the spouse and they're sitting in the same room shaking their head. No, they're not. They're not the same person. They're having these types of problems. So, you know, I think that's very critical in trying to understand, you know, mechanisms. I mentioned the idea of PET scans and functional MRIs. They're not widely available. They are in certain research areas, but they're not common tests that you can just go have. I guess PET scans are becoming much more common, and in university settings, in large tertiary hospitals, I think they are available often, and that may help document level of injury. But the bottom line is the most commonly used assessment of that is a person's symptoms. And we talked about the value and importance of making sure that people's symptoms resolve. Early on we talked about even doing some testing where the nervous system is stressed and put in an environment where it has to perform, and making sure that the nervous system functions well. I know we did a study where people had post-concussive headaches. These were military personnel, and then we exposed them to a level of hypoxia that might occur if they were in a helicopter, which isn't pressurized, of course. And so you kind of take a brain at sea levels functioning perfectly normal, and then you take it up 15,000 feet in elevation, and all of a sudden you start seeing a recurrence of subtle symptoms that at sea level really weren't there. So these kinds of stressing the nervous system can help us assess that. But this is an area of much needed research and understanding, and I hope that will be coming in the near future. Thank you.
Our next question is from Jamie. My migraines have been worsening since my car accident 3.5 years ago. I'm so sensitive to so many different medicines, and my headache doctor has recently told me that he's out of options for me. It's such a daunting task to even begin to think about finding a start from scratch with a new doctor or migraine specialist, especially while dealing with the chronic migraines and insomnia. Do you have any suggestions?
Well, yeah, I do. I mean, probably one of the things that I would start with is a support group. I think when headaches become intractable, it's very, very easy to feel as if, you know, you're all alone. You're the only one who's ever had something this bad. You know, you're seeking and looking for ideas. You've reached kind of an end point in treatment with that specific provider or healthcare professional, and it's a very hopeless, sometimes helpless feeling that individuals are left with. So, you know, I probably would look for some type of support group where, one, you can hear ideas, you can communicate with people, and express some of the feelings that you may be experiencing. The other thing that I would look at, you know, I think when we have a very bad case of diabetes or heart disease or high blood pressure or, you know, ulcerative colitis, you name the disease, there's a point at which we think about finding a specialist, getting referred, and I think very often in very complex instances of headache disorders, such as you're describing, looking for sort of an interdisciplinary model of care, where not only do you have a doctor helping you, very often you again have other patients, but you have physical therapists, psychologists, nurses, occupational therapists. You really have a host of professional people that can assist. That could include others such as anesthesiologists. So I really understand and feel for your sense of loss and desperation here, but I really would look for that type of interdisciplinary headache program. You can get on the web and look at, there's several programs, both inpatient and outpatient programs that are available, and I strongly encourage you to try again. I can't tell you in my practice, which is largely referral, the number of times people have come in that sort of desperate state. They don't feel there's anything that can be done. They've been told that, and yet in reality they've done exceedingly well. So keep after it. Again, what I would probably encourage you to do is look for an interdisciplinary program. Talk to your doctor about it.
Question from Lisa is, can you comment on the use of Namenda in chronic migraine and specifically post-concussion migraine?
Yeah, well, again, Namenda is not an indicated drug. Had a very interesting case just the other day. A patient, we've struggled finding a solution for, and we put them on Namenda, and literally it's been almost life-transforming. It is a drug that does have some small studies to support its use. I think it's a very, again, going back to no harm, it's typically a very well-tolerated drug. A lot of side effects that we commonly see with other preventative medications are not seen with Namenda. And again, it wouldn't be a starting place for me at this point, but I think it is a good second or third line consideration, and I've had patients in whom it's worked very, very well. And that includes for migraine and post-traumatic migraine. In other words, people who maybe had migraine, but after trauma they now have much more migraine activity. So I think it's one of the medications that can certainly be considered.
What do you think about the hyperbaric chamber therapy for post-headaches for the last 2 years?
Well, I think it's interesting. Again, we're talking about these things that really lack scientific understanding. Again, I don't know that there's a lot of downside to it, but I can tell you it's very difficult to find a hyperbaric chamber. Again, I just have to point out it's a pretty controversial therapy, but I go back to, sort of my litmus test. Are we likely to do harm? And I think it's one of those things that you're not, but I can tell you in our area of the country, finding a hyperbaric chamber that would allow that is nearly impossible. So I don't discredit it. I just wish we had, some studies, large studies that looked at this critically and we could answer it for you. I also have a question about sort of the titrating of drugs, starting with low doses and gradually increasing until a final dose, and then seeing if it really works and gradually weaning off. And the question is there a quicker way to assess trial and error drugs? In part, the reason that drugs are started at low doses and increase slowly is the nervous system of someone with migraine in particular is often very sensitive to any type of stimulation. And you know that in terms of light and sound and odors and touch. But it's also true for medication. So the idea is to avoid a lot of side effects, to give the body an opportunity to accommodate these medicines and assess. On the other hand, I think the person asking this question is pointing out something very valid. It can often take a very long time, and then there's kind of this linear thinking that, well, we'll do this for 3 months, and we'll do this for 3 months, and the clock is ticking, and the headache disorder is becoming increasingly chronified. So, I guess one of the things that is commonly done is both in inpatient and outpatient programs with infusion centers is a lot of drugs are tried very quickly, often with intravenous dosing, and that does speed up, to some extent where a drug may be important. I think, again, that's no easy answer for everybody, but that's one of the ways that that process is, there's an attempt to try to increase it. So thank you. I really appreciate the questions that people asked. I hope some of this information was useful. I want to be encouraging about management and treatment of post-concussive headache. If people are suffering with this often disabling disorder, I just hope that you will pursue finding good solutions, that you will get involved in your own treatment and your own decision-making around treatment. And with time, it's certainly my wish and hope that you will come bring these headache disorders under excellent control. So I thank you very, very much for your time this evening, and again, your excellent questions and fund of knowledge. Thank you.
I'd like to thank everyone for joining us this evening. We'd like to especially thank Dr. Cady for joining us. Please check out our website, headaches.org, for our upcoming chats during Migraine Awareness Month. We will have one per week. There will be one each Tuesday. And again, thank you for joining us and have a great evening.